Preserving fertility in cancer is a big enthusiasm of mine, and something that I'm now spending about half my clinical week on at the moment. Preserving fertility is quite big news anyway, isn't it? Putting one's fertility on ice. And I think there are a number of reasons why women might wish to access this. What we're going to talk about is the top of that list, women who are being treated for malignancy. But also there are quite a few serious benign diseases. For example, sickle cell anemia is now sometimes treated with bone marrow transplantation, and that in itself is likely to destroy fertility. Then there are the women in the hands of the gynecologists having pelvic surgery, repeated ovarian cysts, repeated surgery for endometriosis, gradually chipping away at their ovarian function. There are women who are at risk of early menopause because of a familial tendency or genetic condition. But probably the biggest number of women going through the hands of IVF doctors at the moment for fertility preservation are those who want to do it for personal reasons, and in particular to avoid age-related infertility. And it is quite big business. I thought that this intelligent young woman on the phone with her laptop might indeed be a lawyer, and this ad is aimed at her. So she's not quite ready to have her family, and she's looking at this free egg freezing advert, but as lawyers, I'm sure you're used to reading the small print, and the small print here says that free egg freezing is part of our egg sharing program. So that means that half of your eggs are going to be donated to some other woman, no doubt someone slightly older, who is no longer able to achieve a pregnancy on her own. Anyway, I'll just throw that in as something that you might look at in the sense of women's reproductive rights. The other way this hit the headlines was 2014, I think, when some big firms announced that they would offer egg freezing free to their employees, one of them being Apple. But I'm going to leave that aside now and concentrate on the subject of my talk, which is women approaching treatment for cancer. This is just to show you the trend on these lines. It's upward. Survival over the last 40 years has improved in virtually every diagnosis of cancer. The purple line there is breast, which is of particular interest, I think, to the audience. And this means that we're not just looking at treatment aimed at allowing survival. We're looking at long-term survival beyond that, and that's why fertility is becoming so important. Cancer treatments cause fertility in two ways. There's the chemotherapy, which destroys dividing cells. That's how it works, and that's why it has so many side effects, such as hair loss. Now, the eggs are held in a state of cell division in one's ovaries, and so there is the loss of quite a large number of eggs during intravenous chemotherapy. And the way that women are made, if you lose your eggs, you also lose your estrogen, and there is a risk then of an early menopause. Men are a bit different in that regard. Sperm production is very sensitive, but hormone production in the testis is pretty resilient. The other way that treatments for cancer cause problems is with radiation. And radiation to the pelvis damages egg production, but it also damages the womb and thus your ability to carry a baby thereafter. I won't go into too much detail, and wave at me if you think it's getting too much of a lecture. But one can try and stratify risk for different cancers. And this is a well-known slide, which is on the American, well, in a complex form. It's in the ASCO guidelines. So the people most at risk are generally the women who are most seriously ill and whom it is hardest to help. For example, the ones that are lined up for transplant. The group that we're more likely to see, actually, are the people at medium risk, and in particular, breast and lymphoma, because these are the commonest cancers that are occurring in this age group. From the patient's point of view, it's a really important discussion. And when you ask people who are cancer survivors what their biggest health concerns are now, fertility is top of the list. And sometimes it's surprising. I might see somebody who's had a sarcoma and they've had an amputation. And dealing with a prosthetic limb, to me, would be a very, very serious impairment of my health. But actually, for them, fertility may be more important. It's got effects on one's self-esteem, one's confidence, building up a relationship and the disclosure that you know you're probably infertile. And that leads to difficulties with sexual relationships as well. So overall, quality of life is very much affected. Before starting on fertility preservation, I thought I'd just spend one slide on treatments for cancer that are improving the outlook for fertility. Down there at the bottom left, a good example is surgery. Sorry, that's a really horrid-looking picture, but that's supposed to represent an early-stage cancer of the cervix, seen as though somebody were doing a smear test, seen down a speculum. So the classic treatment for this was a radical hysterectomy. But if it's a small and early-stage cancer now, the treatment is to do a radical removal of the cervix, but hang on to the uterus. So that woman could potentially get pregnant and carry a pregnancy, and about half of them do. Then we've seen lots of changes in chemotherapy regimens, changes in breast cancer regimens, less toxic agents being used, Hodgkin's, shorter duration, 3 or 4 cycles instead of 6 or 12, what's called reduced intensity stem cells. So all of this is very positive news. And what's on the horizon in the UK now is proton beam therapy, which is a much more targeted form of radiotherapy. And there's a unit being built at the back of my maternity unit. So the road's been dug up for the last 2.5 years, I think, while they put in some huge cyclotron into... It's about the level of the underground station. And there's one at the Christie in Manchester. So then we're getting these referrals, and probably the key to success here is getting the discussion right. It needs to be done well, and it needs to take time. The assessment that I need to make as a medic is, well, firstly, I need to know the predicted effect of the treatment on fertility, but I also need to know a bit from the oncologist about prognosis, because I'm hoping that this young woman is here because the treatment is aiming to cure her. And it can be very difficult when I find that the woman in the room actually has metastatic disease. She has a life-limiting condition, and her expectations are not fitting with the reality of her treatments. I also need to know the time available. Haematologists are legendary. They say, could you freeze eggs for this young woman? By the way, her chemo's booked for Monday. They're also on a slightly different page from me when it comes to health and risks, because they will often send somebody who's got no platelets, so the blood clotting's absolutely up the chute. And I'm not very happy then to put them through an operative procedure. And then finally, the patient's age is quite important, because we may be seeing teenagers, so there are all these issues of physical maturity and also ability to understand this information and process it and really give proper consent. So now I'll just get on to the meat of the talk about what we can do now to preserve fertility. Well, perhaps before I start, I'll just concentrate on that little canister, because that might be new to you. This is about cryopreservation. And in this, that little straw there will be some embryos or some eggs going into liquid nitrogen. And so at the back of our unit, there's a room which is monitored, padlocked, alarmed, etc., full of canisters, full of very, very precious human material that can be kept at very low temperatures. But to get there, for women, main way is to go through the first half of an IVF cycle to extract some eggs. And some of you may have personal experience. Many of you probably will have friends who've been through IVF. It's not an easy process. It starts off with being taught to inject yourself and having a course of stimulating drugs for the ovaries every evening for 10 or 12 days. Then that is monitored. So during those 10 or 12 days, there'll be about 4 visits to our unit for a transvaginal ultrasound, where we look at egg number, size of the follicles, and decide when to harvest. We measure estrogen, and if these are days of the cycle, estrogen will climb, all the little follicles will be marked on the graph, and they'll get bigger and bigger until the point where they're mature, and then we book a day case admission for an egg harvest. These are my colleagues south of the river at Guy's. So this woman is going through the process of egg harvest. It's a transvaginal ultrasound machine. It's got a little tube with a needle that is going through the vaginal wall, and the fluid is being sucked out, and the embryologist behind is picking the eggs out from the fluid immediately. Now, actually, it's not as big a procedure as it looks, but it wouldn't be very comfortable, so this young woman's under anaesthesia. It takes about 20 minutes, probably a stay of a couple of hours in hospital. And then what we have under the microscope is an egg, or hopefully we have 10 or 12 eggs. These are very large cells. I think they're the largest cell in the human body. You can just see them. It's like the tip of a pin, the size of an egg. And they're surrounded by a little cloud of nourishing cells here. Now, these were very difficult to freeze. They're full of water, and the genetic material within the egg is spread out in a state of cell division. So they were very vulnerable to freeze damage, and it wasn't until we got vitrification, which is 8 or 10 years old now, that it became a successful technique. So we either freeze then, or we fertilize the eggs and we grow them as embryos. And this is a 3-day-old embryo. This is a 5 to 6-day-old embryo, beautiful embryo. It started to hatch out of its capsule, and we can freeze embryos. Now, the difference between those is that we've been freezing embryos a long time. It's a very well-established technique. We've been doing it since the mid-1980s. So it's got a track record of safety. We know it works. The difficulty, of course, is that this is only applicable if women have a partner with whom they can freeze. And it also means, because of the regulatory environment, that they have to be in a pretty committed relationship, because if they come back in future, their partner has to give consent to use. And there have been a couple of very high-profile cases, one of which went to the Court of Human Rights, and that woman could not use the embryos she had created with her previous partner. So eggs is fairly new, and we don't have a lot of data yet, but it's more widely applicable. It means we can look after younger women, single women, and it's their gametes. They make all the decisions. And for some people, that's also quite a big ethical or moral concern about the fate of the embryo compared with the fate of an egg. I won't kind of go into the figures, but just to say that in the best hands, and that's just, perhaps look at those ones, does pretty well, a pregnancy rate of almost 50-50 per cycle. This is nice to see you coughing there. I know it depends which way you look at it. It's not 100%. But these are the best hands. And also, these are the best eggs, because these series are young women who've given eggs for donation. And that's not quite the same as oncology patients. In Britain, we've lagged well behind, and we've only got data published within the last 6 weeks of our experience, and it's already a bit out of date. But it wasn't too far different between fresh IVF and frozen eggs. I want to talk for a moment about risk, because it's very much a balance of benefit and risks, this discussion. We're talking very theoretically about survival and fertility plans, and the last thing that we want to do is to put that woman at increased risk. So there needs to be a very smooth, well-oiled cog, which is what this diagram's supposed to show, so that she moves seamlessly from the oncologist to the reproductive medicine clinic and back again for her treatment. There are women who feel so strongly that they say, I'm not going to have my chemo unless you do this for me, and I don't care if my life is at risk. Well, that's something perhaps we could talk about over drinks later, how one manages that situation. There are also some physical risks. For example, in breast cancer, these drugs push your estrogen level up hugely, so we use a special regimen with an estrogen blocker to avoid increasing that. Now, I'll just run through the other options. Ovarian tissue freezing is one you might have heard of. I'll do it just in brief. Taking an ovary and putting it in the freezer is technically pretty easy. It can be done very quickly. You could probably get a space on an operating list in 48 hours' time. And it could be at any age. We've got ovarian tissue literally from infants in store. It does need a more invasive procedure to take ovarian tissue. It needs a laparoscopy, so full anaesthesia, day case surgery, and it needs another one to regraft it later for use. At the moment, availability in the UK is extremely limited. There are only 2 centres that are actively in practice with HTA licences. Putting it back, that's just to give you another picture, because I hoped it would be a more interesting talk with lots of pictures. So this is a piece of ovarian tissue that's been sewn back into the pelvis. Can you see the red flare around it? So that's a vascular flare, which is needed because you've got to restore vascularity for that tissue to start working. Most of them do, although it may only last a few months. There is a bit of a worry. Say this was a woman with leukemia. Has that ovarian tissue got some malignant cells, and are you going to put it back? We don't know of any definite cases. This is the first baby born from regrafted ovarian tissue, 2004. This remains one of the biggest series of 60 patients. Most of them the tissue took, but only a minority went on to achieve pregnancy. We don't absolutely know a firm figure, but it's probably a little bit behind egg freezing. And then finally, this was a British first. This was the first baby born to a woman who had ovarian tissue taken when she was still a child. So she hadn't even gone through puberty. That ovary wasn't even working. And she had been treated through Great Ormond Street for thalassemia major with a bone marrow transplant. And her tissue was stored on an experimental basis in Leeds. When she came to have it back, she actually couldn't get it done in the UK because of our regulatory licensing arrangements, and had to take the tissue overseas. But she had her baby in London. And then there are 2 more to talk about, a bit of a whistle-stop tour. There's a lot of interest in hormonal protection. If one can't actually physically extract gametes or tissue, could we quieten the ovaries down so much that we shield them from chemotherapy? These drugs are used quite widely to suppress menstruation, and for a lot of oncologists, that's a real plus. They don't want women to be menstruating because their platelets are low, they've got a bleeding tendency during chemo. They may be transfusing a woman during her period whilst having chemotherapy. But it's thought that analogues may also provide some protection by preventing egg development coming forwards in the waves of development that occur. The evidence so far is only positive in breast cancer. There are randomized trials. They're statistically significant, but they're not clinically terribly significant. You know, the benefit's not that great. And then the very final thing I'll mention is moving the ovary out of the way of radiation. And this rather lovely picture was given to me by Hamish Wallace, who's a paediatric oncologist in Edinburgh. And it shows the hot spots of take-up in a patient with lymphoma. So it outlines all the spleen, the lymph nodes, all the way down the aorta and down the pelvic vessels. And they were going to irradiate all of these. So if the ovary would be hanging around there, that ovary is going to be a garner, and the other one probably will get some scatter. And so one could do keyhole surgery, pick up and hitch the ovary out of the radiation field. This is a different patient. This is somebody who was having radiation to the opposite side of their pelvis, and that ovary is that white thing there, has been stitched to the ligament. Normally, that ovary would be hanging down here because it's on a it's quite mobile. And that was released subsequently, and the woman resumed menstruation. So there's a lot of research going on in this field, and what everybody asks me as they come in is, what about stem cells? And I said, actually, I don't know. What people have been working on a long time is to try and take ovarian tissue and mature the eggs from it in the laboratory. And they've been saying, oh, this is 5 years away for all the time I've been interested in it, which is 15 years. But it is getting closer in Edinburgh. There are some experimental approaches of in vitro activation, meaning you take the tissue and you activate it with chemicals in some way and you put it back. Slightly bizarre. And there's, as I say, there's a lot of stem cell research, and the jury is out as to whether or not stem cells do exist in the ovaries that could regenerate. Finally, the proof of the pudding's in the eating. We don't yet know what the long-term outcomes are going to be for fertility preservation for women because it's too new a field. We do know a bit about men. This man in this photograph was somebody treated in our unit, and he came back almost 20 years later. Sperms survive freezing extremely well, and we think that eggs and embryos do too. So we don't think that duration of storage is going to be a problem. But what we have also found from men is that only 10 to 15% come back and use their samples. So we have very large numbers of men whom we cannot contact, and we have a legal obligation to keep their samples for a certain duration of time according to their consents. And this is a bit of a worry about building up banks of eggs and embryos. And it does lead to some difficult ethical situations. I don't know if you can read this clip. So you can see the date on that. That's 20 years old. That was in America, of course. But there has been quite a recent case. Some of you, I don't know if you were involved, anyone here, in a similar situation in Britain where a young woman had stored her eggs and then died from her disease. And her parents were denied the chance to use those gametes because of the consent arrangements. But they took the HFEA through to the High Court to get an export license so that they could go overseas to have treatment. And then finally, because I thought that you might want something about rights, as it were, I thought I'd just give a little bit about provision and where we need to go. And this will be just the last 2 minutes, so I'm ahead of time. It varies hugely worldwide. It varies according to the development of the country, obviously, because it's pretty high technology. But it also varies according to the laws and the religion in different countries. As an example, in the 1990s, Italy was in the forefront of developments in this field because they weren't allowed to store embryos. So there was a lot of work on egg freezing. As of last year, there are about 160 centres worldwide had signed up as being fertility preservation centres. There is a very large and active consortium that's based in Northwest USA, the Oncofertility Consortium, which has a very good website with information. Within Europe, the biggest program is in Germany, who have linked with Austria and Switzerland, and they've formed a professional organisation called Protect, and they have got an amazing registry and database, so they can keep tabs on all of their work and look at outcomes. In many countries, finance is a big concern. So in America, egg freezing, I don't know, $10,000. It's just not accessible. And so there are charities such as this that will support young women facing cancer treatment. So in Britain, of course, we have the NHS. Historically, we haven't done very much egg freezing. One of my colleagues, Cheryl Fitzgerald in Manchester, put this data together from a Freedom of Information request, so it's now 5 years old. But there were very few regions of Britain doing very much fertility preservation. It's not recorded separately in our national data. So what Cheryl had to do was to ask for NHS-funded cycles, because that obviously would be a marker that these are ones for oncology patients. And I'm hoping we'll repeat this survey 5 years on this year. One of the reasons I got involved with NICE was that I was keen to do two things, really. I wanted to get single embryo transfer on the map to avoid the risks of multiple pregnancy for so many women, but I also wanted to get cancer fertility preservation on the map. And so it is in NICE guidance, and there is a NICE quality standard saying that women should be offered this, but it's not implemented around the country. There are practical problems as well, because oncologists are not linked to IVF units. They're often very disparate referral pathways. Yes, I do a lot of referring women for information. This is the HFEA website. But I also refer them to something called fertility fairness, because it's the only way to find out whether or not they'll be funded. Because I might be seeing somebody, I'm in a tertiary centre, somebody from elsewhere in the south of England is not going to get IVF funding for UCH, not if they live in Brighton. So it's very difficult, and it's very hard for the oncologists to cope with this. We tried to get some professional publicity about 18 months ago with an editorial in the British Medical Journal, drawing attention to the needs here. And we've now produced some national guidance with the British Fertility Society, which has had very good press and take-up so far. So that came out in January of this year. And then finally, I chair a small professional network. So we've got links, and we've got a mailing list. And we're supported by all of the relevant professional societies, such as the fertility nurses and the andrologists, to try to improve practice, improve information, both for oncologists and for women whom we look after, and to streamline this process so that we can go through that sort of fast cog of seeing a woman, providing information, taking her through if she wishes to do so, and getting her back to the oncologist in good time. So that's a fast tour of a fast-moving field. Those were my take-home points. Increasing success of treatment means the emphasis is now on quality of life in long-term survival. Infertility is a common outcome, rated very highly by patients. We can do it for men, but it's only recently we've had these developments in the technology to do it for women. But access is still quite limited, and that's what we need to work on. So, thank you.